This is your Module 8 on immunology. We're just going to cover a few sections of it for the material that you're covering in MedSurg 2. Well, I'm adding in immunizations because I don't know that it's actually covered in MedSurg 2, but there's no other place it's covered, and this is an appropriate semester to go over immunizations. So a lot of students get confused with active and passive immunity. Active immunity is where your body has to do something to produce that immunity. So immunity in which the antibody production is stimulated without causing clinical disease. And passive immunity is antibodies produced in the human or animal host and then are given to somebody. This is what they call immunoglobulin. It's not a lasting immunity. Like when somebody is exposed to something and you give them immunoglobulin, it's a temporary coverage. But active immunity is when your body produces it. So an antigen is any substance that stimulates the immune system to produce the antibodies, and antibodies, also called immunoglobulins, are proteins manufactured by the body that help fight against foreign substances called antigens. So the average infant born today, if they receive all the immunizations, it covers 16 diseases of childhood. And as we're covering in community this semester, you'll see that there's a lot of outbreaks of things because of people not immunizing. So when immunity is produced, introduce an antigen into the body by a vaccine, allowing the immunity against a disease to develop naturally. That is an active immunity. Oh, hit the wrong button. Okay, so there's different types of vaccines. They have them listed here. Your killed virus contains a microorganism that's killed, still induces the human body to produce antibodies, such as inactive polio virus. Like your, influenza that you'll be given this semester, it is dead. That's why it cannot give you an infection. A toxoid is a toxin that has been treated to weaken the toxic effects but retain antigen. That's what your tetanus, that's why it's called a tetanus toxoid vaccine. You have your live viruses. If you get the opportunity to do any vaccines at the health department, you'll know your live viruses: mumps, measles, rubella, varicella, which is your chicken pox. They're the ones you will get from the freezer or refrigerator. They contain a microorganism that's alive but attenuated. So it's alive but it's weak, so it cannot cause the illness, but your body will produce the antibodies for active immunity. Recombinant forms are organisms that have been genetically altered for use in vaccines, just as the hepatitis B vaccine. Conjugated forms are altered organism joined with other substances to increase immune response. Well, your influenza type B has a protein. Okay. So there's different kind of reactions. These are things to be familiar with, especially when you're given vaccines, because for education, you can have a local reaction, erythema, swelling, pain, induration at the injection site. That is normal, nothing to worry about. Local allergic reaction can happen minutes to even hours after an injection, where they have the rash and itching. Serious reactions are reportable events. There's actually a site that you have to go in for the CDC to record that. If you're working at some place where you're giving vaccines, you will learn that. A systemic reaction, it happens within the whole system. So it's a fever, fussiness, irritability, malaise, loss of appetite. These are non-life-threatening systemic reactions, are just the itchiness, little petechiae that usually goes away. Life-threatening, of course, is an anaphylactic reaction. Contraindications of giving it is acute illness with a high fever. You're not talking 100, you're talking 101, 102, an active infection going on in the body that the body is trying to fight. Hypersensitivity, that's where they're react to it. That's where you're concerned about a possible anaphylaxis. Recent immunoglobulin therapy, there are people with significant immune problems that have to get immunoglobulin, or if they've gotten it for some other infection because they had exposure to something like hepatitis. So you want their body not to have to take on the job of trying to produce antibodies for something else at this time. Cancer treatments, of course, because it's decreasing the immune response. In pregnancy, there is a contraindication for your live vaccines. But yes, you can get the influenza vaccine when you are pregnant. It's the live vaccines you cannot. So immunizations, a recommended schedule, they add some new vaccines. It says updated annually. They do update it at the CDC site. And they give you one for the recommended age range to get them. And if somebody's behind them, there's a catch-up immunization schedule. Every time you're doing a pediatric visit or going to schools, when they come in the hospital, any time a child is encountered, actually an adult, should be also that you should check their immunization. Adults should have boosters of childhood vaccines. That's debatable. The MMR, they're now, guys, some of you may have done it where you had your titers. Some of the titers from the childhood diseases are not always as high as they should be anymore, but the current ruling for the CDC is not to give boosters unless there's been an exposure. Vaccines for older adults, when you go on the vans, I have that whole vaccine schedule for you. Get familiar with the pneumococcal vaccine, the shingles vaccine. What else are the adults going? Asking about their hepatitis. No, Hep B is only if they're in healthcare. And I'll probably touch on some more immunizations in the classroom to be familiar with. Why do people refuse immunizations or refuse to have their kids immunized? This is information to be familiar with because of education and trying to encourage people to have their vaccinations. Concerns that too many vaccines are dangerous and can be harmful to a child. There is so much stuff out there that is not true, such as causing autism. There is absolutely no evidence to support that. There has been so many studies. Belief that vaccines don't work. A lot of people think that, but it is proven that they are effective, or at least effective most of the time. Like the influenza, at least you might have a lesser of the disorder. Disagreeing with government regulation, they don't like being told that they have to do this. Belief that herd immunity will protect a child, that's when the majority of the area has had it. Unfortunately, our herd immunity has decreased so greatly because so many people have chosen not to immunize. They haven't seen these diseases out there, and so now we're having outbreaks of measles and mumps and other things that we'll cover more in community. Belief that natural healing methods are superior, which is untrue. Previous negative vaccine reactions in family members or friends, or what they think was a negative, or they think they got the flu from exposure. I went over the contraindications. If they had immunoglobulin therapy in the last 3 to 6 months, I don't know that I said that. And hypersensitivity reaction on the contraindications, if they had specific components, eggs can be that. There are some influenza vaccines that have an egg component and some do not, so you need to know which vaccine you're giving if somebody has an egg allergy. Parental rights and informed consent. I have the site here. There's a link. I'll probably pull it open in the class. You can go to this site on the CDC. It's your VIS, your right here, your vaccine immunization statement. There is a VIS for every vaccine that is given. You can pull them off of the CDC site. If you are given vaccines, you should have these available to people to educate them on their information. In most places, it is the nurse the RN that has to inform the parents or the person getting the vaccine about it and supplying them the information. Your text has patient teaching on immunizations that you should look over on page 479. Now we're going to go into the pharmacology for rheumatoid arthritis. So the rheumatology for approaches, aspirin or other NSAIDs, minor analgesics to reduce the inflammatory process and manage manifestations of the disease. They will help with the inflammation, but they don't stop the damage. Low-dose oral corticosteroids, usually prednisone, to reduce pain and inflammation. We'll go into that a little more in a later slide. Lots of drugs they call DMARDs, or disease-modifying anti-rheumatic drugs. And intra-articular corticosteroids is where they inject them directly into the joint to give temporary relief of patients that have failed to have the inflammation controlled by other methods. Okay, so your non-steroidals, we're going to probably hit on these every single semester. They're used for so many things. I just wrote here your aspirin, ibuprofen, naproxen being over the counter. And your prescriptions, diclofenac, indomethacin, meloxicam. These are all COX-1 and 2 non-selectives. The only selective COX-2 that's still on the market, Celoxisib or Celebrex, that there's concern with cardiovascular risk, so that's a precaution or contraindication with those. In your drug handbook, you have a whole section on non-steroidals. It gives you a little more information on the forms that they take. The common things you'll see is a high risk for GI problems and bleeding, especially with aspirin. Let's see, need for multi-doses a day. It depends on the prescription. Like your aspirin is usually, can be more than once a day. Your ibuprofen, 3 times a day. Your naproxen is twice a day. Diclofenac can be once a day. Meloxicam once a day. So it depends on your thing. So your COX-2 inhibitor is that it's more selective to the prostaglandin synthesis, so not so much blocking those prostaglandins in the GI tract, so there's less risk there, but increased risk for heart attack and stroke. All non-steroidals have a risk of irritating the stomach lining and causing bleeding ulcers. Again, look over your non-steroidals. I would focus on the drugs that I have listed here. Just, let's see. Non-steroidals might cause some fluid retention, indigestion, diarrhea. Teaching them to watch for tarry stools for any signs of bleeding and stopping the medication immediately. So, oh, I didn't realize I had a slide. Okay, take with food. Do not take over-the-counter NSAIDs. If on a prescription NSAID, a lot of people don't know. You can't just say NSAIDs and can't say don't take one of these that's because you're taking a prescription. You need to write down, educate people on the multiple anti-inflammatories that are over the counter. They may take Excedrin, but there's Excedrin that has ibuprofen, there's Excedrin that has aspirin in it, and then there's some Excedrin that's just Tylenol. They need to understand acetaminophen is not a true NSAID. They may have a prescription such Lortab has aspirin, has acetaminophen in it, but there's like Vicaprofen has ibuprofen in it, which is an NSAID. So you need to be familiar so you can teach your patients. Don't take aspirin if there are any other kind of blood thinner because the risk of bleeding. They may take it with an NSAID with a PPI, proton pump inhibitor, which you should remember those, like your omeprazole, pantoprazole, which is your, to decrease that GI bleeding irritation. They should report their indigestion, stomach pain, tarry stools. And aspirin toxicity, one of the signs is having tinnitus or ringing in the ears, which is reportable, and stop the aspirin. NSAIDs are contraindicated if they have a renal impairment some NSAIDs with cardiac disease, and also contraindicated if they have significant liver disease. Usually with rheumatoid arthritis, NSAIDs are the first prescription they try, but they're inexpensive. They're effective in taking down inflammation and helping with analgesic response for pain. It just doesn't stop the disease itself. Problems with the GI effects can interfere with your platelet function, especially your aspirin. Different NSAIDs, people may respond to one and not to others, so you have to, if one doesn't work, you may try another. Monitor their kidney function, and different NSAIDs, the newer ones especially, the cost can be a factor. So your corticosteroids, they suppress the cell-mediated immune reaction, decrease tissue damage due to inflammation. They're much more potent than the non-steroidals. Prednisone is the most common one. Cortisone may be injected directly into the joint. They're excellent, fantastic in relieving pain. If they have long-term use, there's lots of complications that can happen with long-term use of corticosteroids. Never stop abruptly. We've talked about that before because your adrenal function is suppressed. Corticosteroids are glucocorticoids. Glucocorticoids produced by your adrenal glands, so they slow down or shut down when you're on corticosteroids. So if you stop abruptly, you'll go into your adrenal gland will not be functioning, and it can be fatal. So tapering needs to be supervised. Some side effects: insomnia, because it makes you very hyper, heartburn. Again, the prostaglandin effect, mood swings, increased appetite, delayed wound healing. Some other adverse effects: muscle wasting, osteoporosis, because it causes poor bone density. Cataracts and glaucoma from long-term use of corticosteroids. Peptic ulcers can be not necessarily dose dependent. It can happen to anybody. If they're on corticosteroids, it's suppressing their immune system, so don't give them any live virus vaccines. It can be cautious using corticosteroids when they're in hyperthyroid, because it revs everything up, which hyperthyroid already does. Cirrhosis of the liver is a contraindication. Careful, you should avoid it if they have active tuberculosis and active ulcers. If somebody is going to go on corticosteroids, they may do TB testing. They definitely do TB testing before they start any DMARDs, disease-modifying antirheumatic drugs. DMARDs you will see with other disorders. We're studying it here for rheumatoid arthritis, but there's other autoimmune disorders that they will use DMARDs for. Sometimes they're on more than one DMARD. Okay, so they press DMARDs are immunosuppressive, cytotoxic drugs. They modify the immune inflammatory response. Examples, the ones I want you to focus on that are all in your drug book, are methotrexate, hydrochloroquinolone or plaquenil, and sulfasalazine. They don't work immediately. Some take weeks. Methotrexate is one that actually takes months. It stays in your body about 3 months. They should cause clinical improvement in symptoms. They also can decrease the disease activity, so they have multiple response. They can be given in combination with nonsteroidals, sometimes in combination with corticosteroids. I think I said it, that they need to be tested for TB before doing this. They're contraindicated if a person has an active infection going on. All of these have some toxic effects, and they need to be monitored closely. Here's your monitoring for your methotrexate, monitoring your CBC, because you're looking at that white blood count. You're looking at shifts in your differential, watching liver and kidney function. Methotrexate is metabolized and excreted through the kidneys, so anything that blocks kidney function can cause toxic levels of methotrexate and shut the kidneys down. Avoid echinacea. Echinacea is an herb over the counter that actually does boost the immune system, so you don't want them taking echinacea when they're taking methotrexate because it can impede the function for the echinacea. Avoid pregnancy for 3 months after treatment with methotrexate. As I stated, methotrexate takes about 3 months to show its effectiveness. It also lasts about 3 months in the body before it's completely out. Observe for unusual bleeding. That's not a common, but it can happen. So teach a patient looking for blood in their stools, blood in the urine, easy bruising. Do not take with folate. Anybody that's on methotrexate usually needs to have a folate supplement. Could not get that out. But they do not take it on the same day. Methotrexate, they take their dose once a week, so they take the folate on the days they are not taking the methotrexate. They go to the same binding sites, so if you take them at the same time, the folate and the methotrexate won't completely bind. It'll be free in the body, and you can cause a methotrexate toxicity and kidney failure. Your sulfasalazine, you're monitoring your CBC and your liver function. Sulfasalazine is usually reserved for when other drugs are not effective. Hydrochloroquinolone, which is Plaquenil, it is an anti-malarial drug that has been found to be very effective in autoimmune disorders such as rheumatoid arthritis. They can be on a couple of these drugs like the methotrexate and the hydrochloroquinolone at the same time, and possibly NSAID also. The goal is that these are modifying the disease process where they won't need the NSAID. With the hydrochloroquinolone, again, watching their CBC, monitoring for visual changes. It can cause actually blindness. It's rare, but they have to have annual exams for a specific exam on their eyes. They need to take it with food or milk because it can be very irritating and difficult on the stomach. Again, like with anything, sometimes effective, sometimes not. Everybody is different. Another is your gold salts, which were used a lot before, but since they've discovered DMARDs for quite some time now, they don't use the gold salts as often, so it's no longer a first-line treatment. Your text talks about it being oral and intramuscular. They can be given both ways, and it is well absorbed orally, but the studies show that it's not as effective if given orally. So I just listed here, given the intramuscular, they have to give it weekly for 22 weeks. If they're showing improvement with it, if it's effective, then they continue them, but they slow down to to less than weekly.
Started.
Reduces the disease activity and decreases inflammation just as the others, but it causes significant dermatitis and stomatitis. It can also cause bone marrow suppression and kidney damage, so you are monitoring their CBC, their renal function, hepatic function, watching your analysis, looking for CHF, contraindicated in renal or hepatic disease, congestive heart failure, and diabetes. You're monitoring the urinalysis for proteinuria, and you're monitoring your CBC because of potential bone marrow suppression. Another class is your tumor necrosis factor or TNF inhibitors. They're given most commonly, they are subcutaneous injections. Your text lists one that is given intravenously. I didn't even go there, just these are the most common TNF inhibitors that you will encounter. So you have your, I'm going to give you the brand names, Arava, Nebrel, and Humira, because those are easier to say. If I give it on the test, I am going to give you both names. I guess you should get familiar with the leflunomide, etanercept, and adalimumab. I can't even say them because NCLEX may give it to you in the generic name, not the brand name. So the TNF are tumor necrosis factor inhibitor. Tumor necrosis factors are produced by macrophages or white blood cells that are in your synovial fluid. They're produced by a person with RA, rheumatoid arthritis. Their synovial fluid can form these macrophages. The macrophages are pro-inflammatory, causing inflammation. They also cause remodeling and joint destruction. So they give this to inhibit the TNF production by the macrophages to stop the joint inflammation, joint remodeling, and joint destruction. Side effects, there's a pile of them. The most common to focus on are your headache, skin rash, site injection reaction, and very common for all of them to have an upper respiratory infection. So you're teaching patients to look for those and to report those. Humira has some additional increased risk of serious infections such as TB and systemic fungal infection. Very hard to treat. Avoid those with a history of cancer or demyelinating disorders. The most common demyelinating disorder is MS or multiple sclerosis, which we will get in MedSurg 3, but you would not give Humira in somebody with MS. So the last section for your immune module is your pharmacology for systemic lupus erythematosus. People often just refer to as lupus. It's to manage I wrote the different symptoms, different drugs that are used to manage them. Your arthralgias, arthritis, fever, fatigue, aspirin, and many other non-steroidals, which we have covered. Your skin or arthritic manifestations, because systemic lupus presents very differently in every person, can affect multiple systems, one system. So your skin and arthritic manifestations of systemic lupus are your antimalarial drugs, which is your hydrochloroquinolone or your Plaquenil, which retinal toxicity, blindness with your Plaquenil, so you need to monitor. They have to have their eye exams. Oh, I forgot to mention that. I don't know if I mention it later. Sun sensitivity with hydrochloroquinolone or Plaquenil. So if they have severe life-threatening manifestations, often that's with the kidneys, they will give them high-dose corticosteroid therapy. I'm talking 40 to 60 milligrams a day. Of course, there are risks for significant complications with corticosteroids, diabetes, edema, weight gain, because it causes glucose increase. They can get this moon face. There's a lot of complications. Let's see. Immunosuppressive agents, cytotoxic or antineoplastic drugs, such as your sulfasalazine, cyclosporin is another. They may be given in combination with corticosteroids or by themselves. Any immunosuppressive agent leaves an increased risk for infection, malignancy, and bone marrow suppression, as was covered with the RA drugs. Nurse's responsibility when somebody is on an immunosuppressive agent is monitoring their blood count, especially their white blood count and their platelets because of bone marrow suppression. Monitor for signs of abnormal bleeding. Definitely do your teaching about bleeding and signs for bleeding for the patient. Monitor renal, which is your BUN, creatinine, GFR. Liver function test, your AST, ALT mainly. Administer oral preparations with food because of the GI irritability. Increasing their fluids because you want to keep flushing their kidneys. Meticulous hand hygiene because of the risk for infection is so high. Monitor pulmonary function studies because they can cause upper respiratory infections, and you're checking risk for TB or other respiratory issues. Be alert for dyspnea and cough because of those changes. Teaching for your patient, avoid large crowds because of the immunosuppression. Report any signs of infection right away to their provider. Use contraception to prevent pregnancy or double forms of contraception because they should not get pregnant when they're on immunosuppressives. They should try to avoid aspirin, ibuprofen because the GI and the kidney effect, even though corticosteroids might be given at the same time to manage the disease. Women may not experience menstruation while taking the cyclophosphamide, which is one of the immunosuppressant agents. And again, the dyspnea, cough that they need to report. And that is the end of this presentation.